I now take care of the Methodist Retirement Home, which is located right on the edge of the campus, and it has in it about 200 patients, about 160 of which are ambulatory and about 40 of which in the nursing unit. We're well protected from many of the vicissitudes that other people have. We have really a fairly productive group of people before they became old who come into our institution. And for a good many years, of course, they simply live there as they would live in their own home. They can have apartments.
You are listening to Dr. Eugene Stead, for many years chairman of the Department of Internal Medicine at the Duke University Medical Center. Now, Florence McAllister Professor of Medicine there. Dr. Stead was speaking informally to a group of physicians in a workshop, part of the proceedings of a conference organized by the Duke Center for the Study of Aging and Human Development. The theme of the conference was Successful Treatment of the Elderly Mentally Ill, and Dr. Stead's observations about his experience as medical director of the Methodist Retirement Home came as something of a surprise to conference participants gathered there to review this theme.
And therefore, we have a kind of captive population, which is kind of the middle class, productive, working, Protestant, Bible-loving portion of the community. And up until the time they become senile, they turn in a surprisingly good performance. And when they come to the home, the agreement is that the home will take care of them until they die and supply medical services and nursing services over that time. And so our progression is inevitable. There's absolutely no in-between. Either you die or you become senile. There's nothing, nothing stops you along the way.
I have a question for you. I don't know that it's so clear that if you don't die, that you become senile. That's an assumption that I think is yet to be proven, and the statistics, you can't, it's an argument you can't.
The issues raised by Dr. Stead provoked one of the most lively and stimulating exchanges of the three-day conference, and we'll return to that discussion later. First, however, Wyeth Laboratories and the Duke Center for the Study of Aging and Human Development would like to welcome you to this series of audio cassette reports selected from the conference proceedings and individual interviews with participants. And here is Dr. Eric Pfeiffer, Associate Director for Programs at the Duke Center. Dr. Pfeiffer.
Those of you who have heard the other tapes in this series are already aware of my own bias in looking at the problems of the aging. I believe most of the medical problems of the elderly are treatable, and the techniques that work for people in the younger population, such as individual psychotherapy and group psychotherapy, are equally workable with older patients. These techniques have to be modified, of course, but the knowledge about them, the changes and adaptations that need to be made, is available knowledge that we physicians can use right now. And since we are physicians, not the least important aspect of that knowledge has to do with medications and with somatic therapies. Accordingly, one of my major purposes in shaping the conference was to review where we stand with regard to the somatic therapies. The night rap session among physicians, a portion of which you just heard, was one attempt to do this. The issues raised by Dr. Stead were provocative and stimulating, so I do want to return to them. They are largely ethical issues, value issues, however, and before we get to that discussion, I'd like to look at the basic medical issues, the state-of-the-art of medication with respect to the treatable illnesses. And I think the major general principle here is that we have to recognize that drugs may be metabolized differently in older people from the way they are dealt with in younger people.
I'm very concerned with basic principles of clinical pharmacology: absorption, distribution, excretion, metabolism, kinetics of drug binding, and the basic principles of pharmacology in human settings. And in human settings, unlike animal settings, of course, age is a very important factor.
Dr. Ruben Bressler, head of the Department of Pharmacology at the University of Arizona, is both a physician and pharmacologist. He was one of our featured speakers at the conference. Dr. Bressler, during your workshop you pointed out 4 reasons drug effects are likely to be different in the elderly. What's the first?
Classically, aged people have decreased renal function. An impaired kidney, which occurs with age, very, very much attenuates the ability of a person to get rid of a drug. Digitalis is a classic example where if the kidney function is off a small amount, then a routine, usual dose of a drug will be an intoxicating dose, an overdose. The kidney doesn't filter the drug, therefore the drug is not eliminated in the urine. Now, this is true of many agents, so that's one important point. Secondly, the older patient has a greater degree of fat than he has of muscle, so that you may be 140 pounds and say 60% of muscle, dry weight, and 10% fat. His fat content goes up, his muscle content goes down. Why is that important? Well, one doesn't store drug in muscle, one stores drug in fat. So therefore, the drug will persist in the body for a longer period of time due to storage in the fat. That's two, so kidney and storage. The third problem is even more serious. Due to the limited circulation and the probable impairment of the brain itself, certain cells have died due to poor perfusion. There's a certain attrition that just occurs with living. His brain is not capable of recovering or is not being well perfused. He doesn't have good protein synthesis to renew things in his brain. Therefore, he's more sensitive. So when you add together the altered sensitivity, sometimes more sensitive, sometimes less sensitive, the impaired kidney function, and the propensity to store more in the fat, you got a different scene than you would in a 20 or 30 or 40-year-old. These things have to be considered. But another thing, which I've mentioned before, which is very important, is that one rarely gets an agitated elderly person, certainly in his 70s, and says, well, the man is free of kidney disease, he's free of diabetes, he's free of hypertension, he's free of congestive heart failure, he's free of cerebrovascular insufficiency, he's free of the multitude of diseases that man falls heir to as he gets older, and many of these are treated by drugs. Now you have the problem of not only a limited kidney, more fat storage, altered sensitivity to the nervous system, but drug-drug interactions. And these second drugs, let's say he's being treated for heart failure or hypertension, may drive the psychotropic drugs or the neuroleptics off their binding proteins. It may accelerate their metabolism or decrease their metabolism. It depends on what drug we're talking about. Both types are known. Diphenylhydantoin decreases the metabolism of certain drugs, and Coumadin increases, and barbiturates increase the metabolism. So now you can't be sure you can count on the level to get the effect you've got in the absence of the second drug. So the drug-drug interactions are potential complicators of good routine therapy. And drug-drug interactions are really interesting. They can drive drugs, psychotropics, off carrier proteins. And of course the tricyclics are extensively carried on carrier proteins. Secondly, they can interfere with renal function, specifically the function by which the kidney puts active drug out into the urine to get rid of it. They can inhibit or accelerate the actual metabolism of drugs by the liver.
And yet we need to use psychotropic drugs in the elderly.
There's no reason to feel that you can't use all the drugs that you want to use, as long as the physician is aware of what he's doing and a propensity to get into these difficulties and makes the proper adjustment. So one likes to sit down and plan out his drug therapy and say, look, I'll have to use a tricyclic. It's going to make urination a little more difficult. It's an anticholinergic. Digestion may not be too hot. Sleep disorder is my biggest problem. I'll give most of the drug at night. One doesn't get up to pass water at night, perhaps. Maybe you'll be doing him a favor by not making him get up at night. So I think awareness of the propensity of a drug to get you into, I hate to use the word side effects because they're expected effects. You pay a price for every drug you use. And you have to ask yourself, in light of what I need the drug for, can I take the price? And obviously, in terms of a depressed elderly patient, where his place in society, his acceptable role is an important point, yes, the price must be paid.
I think the most important things about treating the elderly patient with mental disorders is that they have many of the same mental disorders as younger people, but their requirement in terms of the drugs used to treat them may be that they need lower doses.
That was Dr. John Davis, Director of Research at the Illinois State Psychiatric Institute, also one of our workshop leaders. As a generalization, most of us would agree with these remarks about using medication in the elderly.
Their drug treatment is somewhat different because they may require lower doses of the drugs. Elderly patients with anxiety respond to benzodiazepines much the same way as younger people respond to benzodiazepines, except that they may require lower doses. On the other hand, some elderly patients may require normal adult doses of psychotropic drugs, so that the clinician must adjust the dose according to the patient's response, knowing that the first order of knowledge is to know that the elderly require lower doses. The second order is to know that some elderly may require normal doses.
With these principles from Dr. Bressler and Dr. Davis in mind, it might be helpful to review some of the highlights of discussion about the major mental illnesses encountered in older patients and how we treat them successfully. By far the most common, of course, is depression.
Although involutional melancholia is the name and label that the International Classification of Disease gives to late life depression, it really has no validity, this label.
Dr. Klaus Bergman, our guest speaker from Great Britain, is a psychiatrist and lecturer at the University of Newcastle on Tyne in psychogeriatric medicine. In a talk focusing on the functional psychiatric disorders, he made an important practical point about history-taking in terms of treating depression, which we discussed with him later.
The only distinction that really is worth making is the simple distinction: did this depression begin in younger life, and is this a recurrence similar to earlier episodes, or is this a depression arising afresh, say, in the 50s and 60s, with no previous history of depression in the earlier life? And the consequences are very important. If it is a depression arising from earlier life, then often the treatment of that single episode will leave the person free of recurrence for perhaps the next 4, 5, 6, 10 years, or perhaps even the rest of their life. Because if you take episodic or cyclical depression from earlier life, this often has 10-year remissions, sometimes lifetime remissions, and that doesn't change that much in old age. But if depression begins in later life, then the precipitants are either the life situation plus the personality, acute or chronic illness, or disease of the brain which, though not impairing mentally, still upsets the equilibrium, like an acute stroke, which leaves you mentally intact, but can leave you very depressed afterwards. And these latter conditions are the ones which you treat successfully in the short term, but in the long term you keep getting recurrences, which is not surprising, because the precipitating things are still present afterwards and have to be managed and coped with if that person's to be helped to live well.
Now, Klaus, you use ECT in treating depression in the United Kingdom just as many of us do here. It is effective. Do you use it regardless of the nature of the depression, whether it's a single episode or one of the recurring series of depressions as you've just described?
The criteria for using electroconvulsive therapy are regardless of which type of depression. They are more to do with the likelihood that this depression is going to be dangerous to life or health, because many elderly depressives begin to refuse fluid, not take their food, stay still for so long that they're more liable to pneumonia or to pressure sores if they stay in bed. And it isn't simply a matter of being able to wait. If you wait long enough, they become dead. So either you have to treat with drugs, but then if they don't respond to drugs, as they often don't at a given dose, if you push up the drugs, it's more dangerous than giving electroconvulsive therapy. So often electroconvulsive therapy becomes the treatment of choice in severe depressions, especially if they don't respond to drugs. And it's remarkable how frail and how ill people can be and still be able to receive it with benefit. I've had people who've just recovered from heart attacks, people who've had severe chest trouble, people who are very fragile and frail, but given in a general hospital setting, and I'd like to emphasize that, with trained anaesthetists and the possibility of good resuscitation, it seems an extraordinarily safe procedure. And I've had few bad side effects, and I think only one death in about 5 years. And I'm not certain that it was from a heart attack. That wouldn't have occurred anyhow, but of course you can never be certain. I understand this is different from the United States, where in state hospitals the state legislature is very much against giving ECT without multiple checks, and they are very frightened and cautious about it. We tend not to be quite so cautious, and we've had great success with it.
Now, in this country, we almost always administer a short-acting anesthetic and muscle relaxant when we give ECT. Is that true in your practice, too?
Yes, and this modifies the convulsion to a minimal fluttering of the fingers and toes and a twitching of the face muscles. And this reduces the chances of fractures, bruising of bones, severe headaches, and choking. And afterwards, the patients are nursed during the post-operative phase as for any anesthetic, but within 10 minutes they're up taking a cup of tea, and within about half an hour they're back in the day hospital or on the medical ward, psychiatric ward I mean, back at their day-to-day jobs.
What about drug treatment in depression? Would you say the tricyclics are pretty much the drug of choice there as they are here?
Oh, indeed, the drug of choice is the tricyclics, but we have found some place for the use of monoamine oxidase inhibitors. But I think it would, from an instructional point of view, it would be wrong to place them in the same league as the tricyclics.
Do you use lower doses with your older patients?
All elderly people should be medicated very cautiously. You are giving a potent drug with potent side effects to people who are susceptible. And therefore I always start in what, for a younger person, would seem laughable doses. For instance, with imipramine, where in adult life you might start, for younger adults, with 25 milligrams 3 times a day or multiples thereof higher. With elderly person who is frail and perhaps a bit physically ill, I would start with 10 milligrams 3 times a day. And so I would wish to do this, to either step up that small dose until there's improvement, or until I detect the first of the unacceptable side effects. And whichever comes the first, I react to. So if there's improvement, but I'm not yet up to a full young adult dose, I simply continue on the smaller dose. And if there's no side effects, I step it up to the normal adult dose.
Thank you, Klaus. We'll return to our discussion with Dr. Bergman a little later in this program. But first, let's look at another common mental health problem with the elderly, the agitated, depressed patient. Here's Dr. Bressler again.
The retarded depressive will sit in the corner and he won't communicate with the world, and he may weep when you push him for conversation, and he's very unhappy. He's retarded. He responds quite well to a tricyclic. Okay, now there are a spectrum of other depressives that range from anxiety-ridden patients terrified of great apprehension about unknown things. They don't know why they're afraid, and they're very upset, ranging to agitation where they'll break things and fight with people. But as the anxiety and the agitation gets more severe, one adds phenothiazine to the tricyclic. Now, what's the order of response? In general, the order is this. The first thing that's treated by such a combination of tricyclic plus phenothiazine is, the first few hours to days, there's a diminution of anxiety. Sleep disorders are usually ameliorated and the anxiety level drops. Okay, now, interestingly enough, the sedation that one gets in response to the tricyclic goes away in 2 to 3 weeks. The patient adapts to it. And that's about how long it takes for the antidepressant effect to really come into play. Now, what do you see in the patient? Well, in the first few days, the first week, you see lesser degrees of anxiety and agitation. Then you begin to see an increased interest in the world around him and increased activity. But if you ask the patient at this juncture, when you yourself, the physician or the nurse or the family, is absolutely convinced. They say to, doctor, he's just doing great. You ask the patient, he doesn't know any difference. The patient does not feel any better himself, although he's clearly improved. Now, why is this important? Because the patient now faces a family and a physician who are telling him, Mr. Smith, you're doing very well. Mr. Smith, who was agitated and anxiety-ridden and maybe a little paranoid, says, everybody is telling me I'm doing great and they're lying to me. He may kill himself. You really got to be careful when the family begins to say, doctor, he's really doing better. He's sleeping better. He's up, he's around a bit more. He still doesn't know he's better. You got to be very careful, because the patient often doesn't know he's doing well. And then finally, he knows he's doing well 6-8 weeks later. So that again, in summary, the anxiety appears to be treated early in the game. The depression is treated later. The overt improvement is apparent to everybody, but last to the patient.
The combination of a phenothiazine and a tricyclic to treat the elderly patient in an agitated depression was an almost universal practice among our speakers and participants. They recognized the potential complication of the use of these classes of drugs, well-known effects ranging from urinary retention, postural hypotension and blurred vision, to liver problems, agranulocytosis, and leukopenia. But the trade-off of risk versus benefit within the framework of administering the drugs in much lower doses than are usually used in adults was one which most of our experts were perfectly willing to make. Depression treated with ECT and the tricyclics. Agitated depression treated with combinations of tricyclics and phenothiazines. Psychosis treated with phenothiazines. Elderly patients, as Dr. Bressler pointed out, are subject to the same general problems as patients who are younger. Like younger patients, they may also suffer from anxiety. Here, too, milder anti-anxiety agents like benzodiazepines are generally effective in smaller doses. But what about over-prescribing? The question of abuse. Dr. John Sullivan, chief of the neuropharmacology section of the VA hospital, affiliated here with the Duke Medical Center, offered these observations in regard to their use with older patients.
Their abuse potential is certainly far less than the short-acting barbiturate agents. I think we can safely say that they are effective as anti-anxiety agents. They can produce serious withdrawal symptoms, but that this is unusual.
Dr. Bressler.
High dosage leads to muscle weakness, and it does have a habituation and addiction liability at higher dosage for long periods of time. The danger is to leave the patient on for good. So with that in mind, you would use the benzodiazepines over short periods of time. For the anxious patient, usually one with multiple somatic complaints that comes into the doctor and says, doctor, I cannot go on. I have headaches, I got my eyes hurt, I have back pain, I have this, that, and the other thing. Somatization patients, severe anxiety. And, or I'm scared and I don't know why. It gives the doctor time to establish a rapport with the patient and try to get to the root of the problem. He may decide after a few visits that the patient really has somatic complaints but is really depressed. He may find other things. He may find the patient has a tumor somewhere. If there are many things, it gives him a chance to fight, to really get to know the patient and leave the patient comfortable in the period of time that they're returning. I wouldn't ever consider a barbiturate, ever.
This is the end of side 1. Please turn your cassette over.